Welcome. In today's video, we're going to cover cyclothymic disorder, and this is going to be everything you need to know for your exam. We're going to cover everything from presentation to diagnosis to treatment and everything in between, so you never confuse cyclothymic disorder with bipolar or bipolar 1. This is going to be a complete ready guide in minutes. So let's begin the section, as always, with the question. A 22-year-old woman has had alternating mood swings for 2 years. Her up periods never impair functioning, and her down periods never meet depression criteria. She has never been hospitalized. Which finding differentiates her from bipolar 2 disorder? Lack of major depressive episodes, presence of hypomanic symptoms, family history of bipolar disorder, or duration longer than 2 years. And if you don't know the answer to this question, don't worry about it. By the end of this lecture, you will never get any questions about cyclothymic disorder wrong. So, what is cyclothymic disorder? Well, this is a chronic mood disorder which is characterized by numerous periods of hypomanic symptoms and depressive symptoms. You're going to need the presence of both. That they never fully meet criteria for hypomanic or major depressive episode. That's one of the biggest differentiators from major depressive disorder and bipolar 2 disorder is that in this disorder, the people will never have the full hypomanic symptoms or full depressive symptoms. A key factor to differentiate it from other disorders that these mood fluctuations, they're going to be chronic and they're going to be lasting for greater than 2 years. And if the question stem talks about children or adolescents, in their cases, it only needs to be over 1 year. Cause noticeable distress or impairment. Unlike bipolar 1 or 2, symptoms are less severe, but they are more chronic, often leading to misdiagnosis and mood instability and personality disorder. Something you're going to see in the question stem where they're going to try to confuse you, but just think about chronic lasting than more than 2 years. And the memory hook that I have for this, I would always think of cyclothymia, and I would just think about cycling moods that never reach full mania or major depression. Cycling moods. Exam tip, you're going to look for chronicity and you're going to look for those subthreshold symptoms, which are a key differentiator from bipolar 2 disorder. Don't confuse this with bipolar 1 or 2. There's no full hypomanic or manic episodes or major depressive episodes present. Also, do not confuse this with borderline personality disorder. This is mood instability is shorter and linked to interpersonal triggers. Bipolar disorder people, they might be cutting themselves. They're going to have difficulties in relationships. None of that will be present in cyclothymic disorder. What are the causes? Well, the genetic predisposition, as always, in cyclothymic disorder is going to be similar to that in the bipolar disorder. So, in your exam, in your psych rotations, it's imperative to always ask about family history. Which neurochemical imbalances you're going to see in cyclothymic disorder? That's going to be serotonin and dopamine systems. And as always, with most disorders, the stressful life events can exacerbate symptoms. Exam tip, as I already mentioned, family history often positive for mood disorders. Don't confuse this with the substance-induced mood symptoms, so rule that out with the history. Ask about alcohol abuse, about drug abuse, etc. All of this comes to you from PA Psychiatry EOR study book, in which you will find 120 style questions with a complete detailed explanation of why the wrong answers are wrong. You're going to see a step-by-step approach for each condition. 57 of them are listed on the blueprint. They're all included here. This book will save you time. This is something I really struggled when I was in PA school to find a common source to study, and this book is something I wish I had when I was in school. So do check it out, and in comments, let me know what school you go to. Let's connect. Let's see if I can help you. Let's continue. So the clinical presentation, you're going to see those hypomanic symptoms. They're going to be mild. You're going to see elevated and irritable mood, increased energy or goal-directed activities, decreased need for sleep. They're going to be talkative. They're going to be having some destructibility, mild depressive symptoms as well. That's that cyclo. It's hypo and low, high and low. So you're going to see the low mood and fatigue, poor concentration, sleep disturbance, mild social withdrawal, and the buzzword is chronic. This is chronic. This is lasting greater than 2 years, where hypomania can be 4 to 5 days, full mania is 7. We're dealing here with something that's chronic, about 2 years plus. Don't confuse this with a major depressive episode. The severity and durations are insufficient in cyclothymia. Clinical presentation and a physical exam. These patients are going to present with recurrent mood swings with period of hypomanic symptoms, those are your highs, and they're going to be periods of mood depressive symptoms, those are your lows, fatigue, poor concentration, and so forth. Diagnosis, again, key factor, it has to be present for greater than 2 years, 1 year in children and adolescents. And they cannot be symptom free for greater than 2 months. So that's something they can play in the question stem. So they're going to say the patient is being chronically high and low, and never fully meeting criteria for hypomanic episodes or mania, never full major depressive symptoms. They were never symptom free for more than 2 months. We should be thinking cyclothymia. No history of full manic, hypomanic, or MDD. As always, you're going to rule out the substance-induced mood disorders or other medical conditions related to thyroid or neuro disorders. Exam tip, the cue is chronicity of subthreshold mood swings. Don't confuse it with bipolar disorder. This is lasting longer, and bipolar is more severe. What is the treatment? Well, the first line pharmacological treatment is, as always, mood stabilizer in these conditions. Lithium is going to be a gold standard for mood stabilization. Valproate can be useful if is irritability or if they're dealing with the rapid cycling. And lamotrigine. This is the one mostly prescribed if you're dealing with mostly depressive symptoms. So look for those things in the question stem. Are they asking what is the gold standard? Are they asking you what's the best medication for somebody who's dealing with rapid cycling, who's really irritable, or lamotrigine if somebody's dealing mostly with the depressive symptoms? Adjunctive psychotherapies like CBT and mood monitoring can be utilized in conjunction with pharmacological treatments. And as always, avoid antidepressants monotherapy because this can prevent mood destabilization. Exam tip, focus on the symptoms management and prevent progression to bipolar 1 or bipolar 2. Don't confuse this with antidepressant monotherapy, which can worsen the mood cycling. High yield facts. So let's summarize everything we learned about cyclothymic disorder. This is chronic fluctuating mood symptoms lasting greater than 2 years without a full hypomanic or major depressive episodes. Symptoms can cause distress. Mood swings are more prolonged than borderline personality disorders, and our goal is to prevent progression to bipolar 1 or bipolar 2. So think cyclothymic disorders in the patients with chronic mild mood swings lasting for years. Back to our question. So, in this person, what separates him from bipolar 2 disorder would be the lack of major depressive episodes. Bipolar 2 requires at least one major depressive episode, cyclothymia does not. B, presence of hypomanic symptoms. Both disorders may show some hypomanic symptoms. C, family history of bipolar disorder. Family history overlaps across bipolar spectrum and duration longer than 2 years. Duration does not define the diagnostic difference. So you can have somebody who's been dealing with bipolar 2 for years. So that is the end of the lecture. I hope you like it. Go get them, and I'll see you in the next video.